Um, Hello, and thank you for joining us. I'm Gina, Director of Communications and Events for the Quantitative Biosciences Institute at UCSF, an organized research unit under the School of Pharmacy. And you are watching a panel discussion for Breast Cancer Awareness Month on QBI TV. Did you know 1 out of 8 women are diagnosed with breast cancer? A breast cancer diagnosis often leaves people with 2 vital questions. 1, is chemotherapy needed? And 2, will the cancer return? My sister and I found ourselves asking these questions when she was diagnosed with breast cancer in 2018. Today, QBI is presenting a conversation with my sister, Angie Turing Nguyen, an elite golfer, breast cancer survivor, and spokesperson for breast cancer. And we're also having QBI faculty member and inventor of MamaPrint, Laura Van Veer. Laura is also an investigator for the Cancer Cell Map Initiative, a project funded by the National Cancer Institute. Thank you both for joining today. Laura, let's start with you. My first question is regarding the series of papers published by the Cancer Cell Map Initiative. You contributed to the one focused on breast cancer. Can you tell us how your lab participated in the study?
Thank you very much for having me on your QBI Live YouTube TV. My lab's work on the Cancer Cell Map Initiative, which is an impressive collaboration between many people at many different laboratories, is actually to this paper that came out about the protein interaction landscape of breast cancer, determined what are the essential proteins that talk to each other and thereby signaling in the tumor that makes that tumor aggressive and maybe also amenable to certain therapies. So you see this very complex picture. On the left, you see the breast cancer in the breast of a patient. In the middle, you see this complex network of nodes, as we call it, of abbreviated protein names like MTDH or GADA3 and the top. And all these lines indicate what this paper has identified, the interaction of one of such proteins in the breast cancer that was cells that were studied here with other proteins. And so we have actually treatments available. Many of them are in clinical trials right now that actually target some of these specific nodes. So you can understand that if the breast cancer existence is because of the interaction of all of these network lines as you see them, if you maybe so-called knock down or inhibit the activity of one of them, that may wipe out the whole cancer. That would be, of course, a purpose of doing this research. So I'm involved at UCSF looking at the biology of actual breast cancers from patients, and we're testing new targeted drugs in patients. So on the right side, you can see in the middle 2 little drug icons, and where it says veliparib carboplatin. And though that drug combination was tested in the I-SPY trial that I'm involved in. So what we were able to do is actually to validate that some of the findings of this network interactions, as you see in the middle, if we indeed one of those would be active in the breast cancers that we see in patients, would that contribute to the likelihood of a response? And that's what you can see on the right. So on the right, you can see in dark blue patients in the trial in an aggregate, but patients that did have a so-called PCR in dark blue. And so PCR means complete response. So that means that the drug in those patients had an effect. And you can see that there is a higher likelihood of such an effect if the gene name that's named here, UB2N, is low. The likelihood is higher than when that same gene is high. So what we were able to do is to show what Minkyu Kim and collaborators found in their model systems in the middle, that was actually true in actual patients. And so such a finding helps us to understand which patients should be treated with what drug so that we can improve the likelihood of response.
Thank you. And what I'm hearing is that this is also conducted via MammaPrint, the test that you had invented. And it's a gene-based test that helps medical professionals offer better treatment. Can you tell us more about MammaPrint and how it's going moving forward?
Mm-hmm. So MammaPrint, so maybe we can, I gave you some slides, so maybe slide 6 is a good one to show. So when patients are diagnosed with breast cancer, as you said, there is the question, do I have a patient have a tumor that has a risk of recurrence? And is that a high risk, a low risk, and how should I be treated to prevent that recurrence? And so I've given here like a short overview from the early 2000s till current. So when patient is diagnosed and the tumor is only located in the breast, then we know that about 2/3, 70% of the patients will be cured by surgery and radiotherapy alone, so as a local treatment. But 30% will unfortunately, as you would not give any drugs in addition to surgery and radiotherapy, then 30% of these patients would develop distant metastases. So in the early 2000s, chemotherapy and endocrine therapy was used as standard of care. And of course, no physician nor any patient wants to have a recurrence. So what was done, that even those patients that had a high likelihood of never getting the tumor back, never having a recurrence, 2/3 of them were still offered or were offered chemotherapy just to make sure that that would not happen. But in fact, if you would be, that led to overtreatment, because these patients in the top actually didn't need it because their tumor was so slow growing that it would never come back. But we had no means to identify those tumors. And the ones on the bottom, those that would develop a recurrence, of course, you want to treat everybody with everything you can think of to have the tumor not come back. But still, in the early 2000s, so many patients were overtreated and a small proportion was undertreated. So what MammaPrint set out to do was to identify in the tumor biology the risk of recurrence. And so to reduce overtreatment and also somewhat reduce undertreatment. And so you can see on the right that since the early 2010s, the so-called prognostic molecular test, so they can predict risk of recurrence, are now in guidelines, and they can reduce overtreatment from 70% to approximately 20 to 40%. So for those patients that are low risk for recurrence, they are safe to forgo chemotherapy. And the way, maybe in slide 7, the way how we did that traditionally standard diagnostics would look at a few characteristics of the tumor. So here you can see on the left and the right side 2 tumors, and both these tumors have this yellow dot. And so in that way, let's say based on this, patient would receive chemotherapy. But if you think about we also looked at the diagram from the CCMI cancer cell map. There are many more proteins and genes that are active in a tumor. So that same yellow dot can either be in a picture of Marilyn Monroe or a flower bed. And that may mean very different things for risk of recurrence. So what in the last 20 years molecular biology and molecular diagnostics has delivered, that we can now recognize if the tumor is a Marilyn Monroe type or a flower bed, or what we actually want to know, which are the ones that have a high risk for recurrence or a low risk for recurrence. So in my next slide, you can see the same pattern, which number 8, which is the same pattern of dots with some imagination. You can see the same pattern of dots in the middle. And you can see that above and below the yellow line, the pattern of dots is different. And so what MammaPrint does, it looks at the activity of 70 significant prognosis genes. And when these genes as a collective are in the off status, which is the good signature at the top, there is a low risk for recurrence. And when those 70 genes are in the on status, as it's in the bottom, you have many more red genes, then there is a high risk for recurrence. So this is a test, we call that test MammaPrint, that we identified when I was still working in the Netherlands at the Netherlands Cancer Institute. But since then we started a company called Agendia and started to do all the steps to make this test available for patients. Did many other studies than this one that you see on the screen. And so the test is now in all clinical guidelines and used for decision making for chemotherapy, yes or no, for women who are diagnosed with early stage breast cancer.
Mm-hmm. And speaking of clinical trials, can you tell us about the I-SPY trials and how that's related to the Cancer Cell Map initiative?
Mm-hmm. So maybe let's go back 1 second to slide number 6, because there's one other little piece of information which is important there. So we now know that patients' biology we can identify by MammaPrint, and there is another test called Oncotype, which is also frequently used in the United States. So we have these prognostic tests. And those patients that are at high risk for recurrence, they need the best therapy we can think of. And in the bottom right, you can see that we know that standard chemotherapy, as it existed also in the early 2000s and 2010, only works for 1 in 5 of the patients. So there is a need for the right treatment for the right patients. And there's also, we'll come back to that later, something about the duration of endocrine therapy. So now if you go to my slide number 5, you can see what we've been testing in I-SPY, that we're really looking under the hood of the tumor. So remember that picture that I showed you with the 2 yellow dots and then with the more elaborate figures. So there's one that you can use for prognosis, but there are other ways that you can look into the biology to find which particular biology is actually making the normal cell, a derailed normal cell, to become a cancer cell. So many investigators everywhere have come, and this led by Hanahan and Weinberg, have come up with this so-called hallmarks of cancer diagram. And around it, you can see all of the processes that cause a normal cell, or can cause a normal cell to become a cancer cell. And often it's not even one of those things that gets derailed, but multiple. So for instance, in green at the top, there are signals in the cancer cell that are continuously on so that they sustain a proliferative signal. And proliferation means that the cell will divide into daughter cells, 4 daughter cells, etc. So cancer is, of course, continuous proliferation, continuous dividing of cells. And there are many drugs, as in that green, that are identified that can actually block that. So if you block that continuous proliferation, that will potentially wipe out the growth of the tumor cells. And so particular patients who are MammaPrint high risk of recurrence, we want to give additional therapy into standard chemotherapy. And from the paper from Min-Kyu Kim from the CCMI consortium, in the bottom left, you can have tumors in blue that are unstable in their DNA, in their genome, and mutate all the time. And there are drugs like veliparib combined with carboplatin that actually make use of this instability to make the cancer cell die themselves and thereby go away. So in the I-SPY trial, we're testing these. We've now tested 20 different so-called investigational drugs because they're not yet standard of care. We first need to develop the knowledge that they can actually be used and for whom. And we're matching the biology of the tumor to the activity of these drugs. And by doing that, so I told you that standard chemotherapy may help 1 in 5 women with high risk with high risk disease with standard chemotherapy. In the I-SPY 2 trial, we brought that to 2 in 5, where the tumor goes away to the treatment, and we have now sort of evidence that we can model that if we do the best we can on matching the therapy to the particular drugs, we can get that to 3 in 5 patients who will respond. And that will make a huge difference, because if you can make sure that the tumor is killed by your initial treatment, then it may never come back as a recurrence. And that's what we would want to achieve.
Mm-hmm.
And of course, nothing is black and white, 100% yes and no, but we're moving towards a way better system to actually match the therapy to the right patient and to the right drug.
Mm-hmm. Excellent, excellent. And Angie, you've lived through this as a breast cancer survivor. I remember the doctor had ordered MammaPrint for you as well. So I wish you were living in San Francisco or California, because you would have been a perfect candidate for the I-SPY trial, since your MammaPrint results came back as high risk for a recurrence. You would have also benefited from the Wisdom program, which we'll get more into later, because you noticed the lump back in 2014, but it took 3 years for you to get a mammogram. We'll get into Wisdom later, but Angie, can you walk us through the timeline from when you first detected the lump and until when you were diagnosed?
Yes. Thank you for having me on today. Back in 2017, actually, I was feeling very healthy, very full of energy. I was probably at my best that I'd been. Actually, I felt like I was 27 and not 47 even. But then by 2018, January, February, I started to have like a flu. I felt like I was just sick and run down, and it went on for months. And even in April, when I thought, well, something is strange about my breast, I knew something looked a little different, but again, back in 2014, I had asked my house doctor, there's a very strange lumpy area on my right breast. What do you think? And she said, well, most women have fibroids and it could be just hormonal. So she sort of said she didn't think it was anything serious. So I didn't think it was serious. So fast forward to 2018, in April, I didn't think it was anything serious because it's that same lumpy area, but now it just felt a little firmer by August. And we're speaking, I felt really completely fine in October of 2017. And then fast forward to August of 2018, I felt this very sharp pain one morning. And I had to go see a doctor anyway. I had moved some plants around and caused a few cuts in my hand. So I needed the doctor to take a look and fix it. And while I was there, I said, hey, by the way, there's this lump that I felt for a while, but lately it feels a little bit harder. And it only took him 2 seconds, but he said immediately, I want you to get a mammogram. And it was, it went so quickly the moment I went in for a mammogram. They moved within 15-20 minutes. A radiologist did an ultrasound, and there he discovered that this was serious and did a biopsy. And the next thing I know, he has he's made an appointment for me to see my breast surgeon to get my diagnosis.
Yeah, and I vividly remember that time I found out about your diagnosis and urged you to get MammaPrint because, I thought maybe we could avoid chemotherapy. But can you tell us about the lumpectomy and the results and do you remember how big the tumor was and, like, did it have clean margins? Did it spread, so forth?
Oh yes. After, well, the the moment you have your appointment to see a breast surgeon, you know it can't be good. So um, immediately, yes, she confirmed it was invasive and said, well, luckily, well, the first thing she said to me was, please take a seat. It is cancer. So that leaves quite an impression. But she did immediately say, luckily, we caught it early. It's early stage, stage 2, and because the size of it was 2.5 inches. However, with the um, with what the original biopsy said was that it had not reached my lymph nodes, so she felt confident it would just be lumpectomy, where it would be breast conserving. We would conserve the breast and try to save it, and then radiation. That would be it, and of course maintenance therapy to have endocrine therapy to prevent recurrence. So and her projection was about 10 years of endocrine therapy. But right after I had my surgery, I did request MammaPrint because of your recommendation. And I had just started radiation and received my results, and it came back as high risk. So and by then I had an oncologist, and she recommended chemotherapy to me. Um, but because, not knowing what my direction was, I did get a second opinion to confirm that chemotherapy was the right direction. Just as Dr. Ben Beer said earlier, sometimes there's over treatment and sometimes maybe there's under treatment. And I just wanted to double check and to find out with a second opinion that this was the right treatment path for me.
And do you recall the amount of rounds of radiation and chemotherapy that was recommended to you?
Yes, originally I would have had 15 radiation treatments, but with the new guidelines, they said that doing it with a bit more intense treatment, we could do it in 8. So I had 8 rounds of radiation every single day, and then there would be a 1 day or 2 day in between. And then I believe it was 6 weeks later, because we didn't want to go straight into chemotherapy after radiation. The body needs to rest. I started chemotherapy and had 4 rounds of AC, and then I had 12 rounds of Toxel, so 16 rounds altogether, which lasted 6 months.
Mm-hmm.
And then after that, a few weeks after that, 6 weeks later, I started endocrine therapy, which I've been on now for 2.5 years or 2 years.
And how was chemotherapy? Did you have any reactions to the treatment?
I did actually, because of we think because of radiation, and just my reaction to Toxo, I developed pneumonitis, which is similar to pneumonia, but it is not pneumonia. So my oncologist did prescribe antibiotics, 2 rounds of heavy antibiotics, but unfortunately it wasn't pneumonia, and so it took 7 weeks before we diagnosed it as pneumonitis, and I began prednisone, and that that really shows the effects of, I mean, it's one thing when you're bald because you're going through chemo, but it's also an added visual for people to see that I was really undergoing treatment when I had moon face and yeah, the weight gain, it was just a whole experience. Fatigue, you name it, nausea, everything just all compiled upon each other, and it was a tough. I would definitely say it's exhausting and extreme to go through that. But fortunately, at the hospital that I was at, the other women who were also going through chemotherapy, of course, we're all in a room together, about 6 or 8 of us. We also would go. We had a fitness physiotherapy in the hospital, which was 2 floors down below, and we would work out together to stay strong enough for the chemotherapy. That was very necessary, and that was something initiated by the breast cancer, well, by the surgeon for the breast cancer um, chemotherapy unit. So that helped me to stay strong to be able to endure 6 months of chemo.
Mm-hmm. And would you like to talk about your maintenance treatment? What has that been like? Are you still on maintenance treatment, and how long do you think you may be on maintenance treatment?
Yes, it's it's one thing when you to begin with the diagnosis is already you're in shock. You definitely feel like your life, well, yes, your life will never be the same. So we always say, before cancer and after cancer, because when I look back, I don't have that innocence anymore of thinking that every day you're granted every single day. Now I don't take it for granted. So the shock of going through the diagnosis and then through treatment was very heavy. But even the after maintenance therapy, endocrine therapy, it is just as heavy because the side effects in the beginning were absolutely horrible. I began with tamoxifen, and they list about 30 different side effects, and I literally had 28 or 29 of it. I mean, you name it, I had it. It was just terrible every single day. So then we switched to because of chemotherapy, I was forced into menopause. I was not in menopause at the time. So because I was already into menopause, I was put onto AI and a aromatase inhibitor of letrozole, but letrozole again also has some heavy side effects. So now, after 6 months of letrozole, I am on anastrozole, which is also an AI. It's slightly better, but again, there are different side effects. It changes my mood. It makes me feel tired and frumpy, and the muscle pain, bone pain, acceleration of osteoporosis. I'm not there, but I'm already at osteopenia, so I'm reaching there. So, instead of feeling like I was 27 back when I was 47, I actually feel like I'm 57 or almost 67. It's such an acceleration of how old you feel after all of the treatment. So I like what Dr. Benderveer had said about how endocrine therapy, maybe we can do better in how we proceed for patients after chemotherapy, because I have to be on it for 10 years, and I just don't know that I really want to have to, do this for 10 years. It is a bit overwhelming.
Mm-hmm. Mm-hmm. And Dr. Laura Van Veer, would you like to say something about chemotherapy versus maintenance treatment?
Yes, I'd like to, but first, Angie, I think thank you so much for sharing all your experiences, because I know there are many scientists listening to our YouTube TV, and I think it motivates us so much that we want to do better, and that we know why we are really trying to actually find the reasons of why tumors grow and how we can stop them, and for me personally also to make them into diagnostic tests. so that patients can actually use it. So thank you so much. And I feel sorry that you had to go through all of that so many years. But hopefully we can do a little better for you over time, and maybe right now. I think I wanted to add something on when do physicians, I'm a biologist, not a physician, but when do physicians recommend chemotherapy and when do they recommend endocrine therapy? So the earlier things that I talked about, the I-SPY trial and how we are combining standard chemotherapy with those targeted drugs is actually to prevent early recurrence. So everybody knows that there's always a risk of recurrence in the first 5 years, which is actually based on a different part of the biology than late recurrences or later recurrences. And the improvement we've made by understanding who is at high risk for recurrence is actually for high risk for early recurrence, so in the first 5 years after diagnosis. And it's known that the chemotherapy, and also we start to see that targeted therapies are particularly important for those early 5 years recurrence. So that's where we have made the improvement. But then, as you said, then comes the so-called maintenance treatment, which is endocrine therapy for patients who have tumors that are hormone receptor, estrogen receptor positive. And in the early years, like 20 years ago, 25 years ago, that was given for 3 years. And then people did a trial comparing 5 years of endocrine treatment to 3 and saw that 5 years overall was better. And then they did a study where they compared 10 years of endocrine therapy with 5 years. And that did somewhat better. So that led to sort of changes again in guidelines and recommendations that 10 years might be better than 5 years, and earlier on 5 years might be better than 3 years. But if you look at those data, also there you can see that the incremental additive effect of longer therapy is for a proportion of the patients, not for everybody. So there again, it's the question of, are we over-treating patients with too long of endocrine therapy? And can we recognize who are actually, based on the tumor biology, the patients who have this later risk that is endocrine sensitive? And this year at ASCO, the results were presented from a large US cooperative group, the NSABP, where they actually had compared that 10 years to the 5 years, which led to the changes in the guidelines. So we got access to that tumor tissue, or for a proportion of the patients where it was available, and actually identified that there is in the MammaPrint sort of mid-range, so this is not very low risk, but also not very high risk. That's the group that benefits the most from that extended therapy, endocrine therapy, the 10 years versus the 5. So that's currently that will be published and will be peer reviewed, and we'll see what happens if that actually can help to identify the patients who really benefit from 10 years versus 5 years. There are other papers already published, which is not relevant for you, but for maybe other patients that are listening, that if the tumor is very slow growing, that we call like ultra low risk, there actually might be an opportunity to actually reduce endocrine therapy really to 3 years. And we have been able to analyze it. I've been involved in a European large trial with 7,000 patients called the MINDEC trial, where the MammaPrint was prospectively tested. In the Netherlands, actually, physicians have been very so-called conservative on giving any systemic therapy. So there's a group of 500 patients in the trial that did not get endocrine treatment because that was the standard in the Netherlands, which is quite unusual, and many people have questioned that. But so that allows us to actually see, is there really a group that has a 10-year no risk of recurrence, or so low that even that endocrine therapy can be shortened perhaps to 3 years. And so there is that group on the very low risk end, which we also previously showed in trials from Sweden, where no endocrine treatment was compared to 3 years, another group to 5 years. So on both ends, things are happening. It's not yet in the recommendations, but both at sort of the low risk, ultra low risk end, as well as who needs these extended endocrine therapies. So I mean, we talked already before we were here together on this YouTube TV. So there's reason to follow this, and I think every patient should keep in touch with their treating physician to see if there are new developments that might be useful to follow up.
That sounds great. Yes, I think I definitely want to keep in touch with my general practitioner about new therapies, changing endocrine therapy, because I know that sometimes, quality of life is also something important.
Yeah.
And to do it for 10 years, if you continue to always feel bone pain, muscle pain, nausea, headaches, I mean, the list can go on, that I think the more that our general practitioners also have access to know what is the latest and best ways to help their patients in the long term, because I know my oncologist will only, I only have appointments with my oncologist as an annual, follow up. How am I doing with medicine? And that's about it. So, yes, that's something I really want to keep, with the house arts here.
Yeah.
Thank you both for sharing and for your answers. I see we have a question from the audience, and the question is: are breast cancer stages determined by size of tumors only?
That's an excellent question. Size of the tumor is certainly part of the stage, but the stage is also determined whether there are lymph nodes involved, number of dividing cells, and so their age of the patient comes in often. So there are many different factors, but actually what is very interesting, the traditional way of, and whether the tumor is located in the breast and the local lymph nodes only, or already in other organs when it becomes stage 4 or advanced breast cancer. So it's a combination of factors. But what is very interesting, that the College of American Pathologists, as in the so-called AJCC guidelines, also start to recognize that beyond age, tumor diameter, lymph node status, location of the tumor, we now have the information of prognosis, high risk of recurrence, low risk, as I told you, mainly Oncotype and MammaPrint. And so they have now made 2 different types of staging. And so one is so-called anatomical staging, which is what I discussed before, but the other is prognostic staging. And prognostic staging takes into account the first level of knowledge about the tumor and risk of recurrence. Mm-hmm. And increasingly, that is starting to be used in guideline recommendations for treatment. And I hope, at least that's something we're working on also in I-SPY, that actually will be beyond prognosis, right, risk of recurrence. We will see within the next 5 years that we also will include so-called predictive staging, which means the prediction to what therapy will help best. So there's a whole movement going on. So whereas traditionally it was anatomical, we now have prognostic staging, and hopefully we'll, in the next 5 years, we'll also have predictive staging.
Mm-hmm. And I'd love to learn more about the Wisdom program. It's clear that the program is needed globally, for example, if this program was available in the Netherlands, Angie would have saved herself years of time and energy. But Laura, as a collaborator in the Wisdom program, can you tell us about how it's designed to prevent breast cancer from occurring, and can you give us some more details about that?
Yeah. So the Wisdom study, we're now going back to the phase that women are healthy and you're being screened, because first of course, you can prevent any breast cancer, or at least prevent advanced stages when you do screening well. So in the United States, there's different recommendations, but usually the recommendation starts to screening by mammography at age 45. But there are so many more advances in science and technology that we can way better predict risk of developing breast cancer. And that's what we have brought together in the Wisdom study, which is in maybe you can show my slide about that, where we make use of all this. So Wisdom stands for Women Informed to Screen Depending on Measures of Risk. And what you can see in the middle in this funnel, that we're using different information, breast density from a mammogram, a health questionnaire about family history, previous biopsy, your age. There's also a difference in risk based on race and ethnicity. And we are using the genomic profiling of germline genes, which can also tell us if somebody has high risk susceptibility gene, as we call it, for breast cancer, then risk is way higher than you have not any DNA change or genomic change for risk. So by using that, all that information in a model, in a combined risk score, we divide the population that we're testing into those from all the way on the right, women that are maybe between 40 and 50, and their risk to develop breast cancer is considered so low that we recommend screening as of age 50, or a little higher, which is an average woman of age 50 has like a risk to develop breast cancer of 1% in the next 5 years. Such a category gets every other year screening. If you above 3%, then it will be annual. And if you way higher, above 6%, we recommend every 6 months. And so in the studies so far, which I can show you in the study recruitment, you can see that we have now enrolled, in my slide 11, we have enrolled up to now over 33,000 women in this study across the United States. Our recruitment goal is 60 to 100,000 women, and that will allow us to compare the current standard of annual mammography with risk-based mammography. And risk-based mammography will increase screening for those women that are very high risk but maybe had no idea, but will reduce screening for actually a large proportion of women. So this is a study in the United States, but as you know, I am from the Netherlands, where there is a very elaborate nationwide screening program. And I'm also still in contact with the people that are involved in that. And there is an activity to actually make this also standard of screening in the Netherlands. But everything takes time to set up, but they may roll out this for everybody in the Netherlands as well soon. And there are other European studies ongoing at the moment.
Excellent. Okay, we have another question from the audience, from Catherine Carlin. Do you recommend that women under 50 get genetic screening to identify risk if we don't have a family history of breast cancer?
So this is actually what we do in the study for those women who are either randomized or choose to be in the personalized risk arm. We do genetic testing of 9 of the breast cancer genes, like BRCA1 and 2, but also CDK2, CHEK2, and others. And we look at other differences in the genome so that we can better estimate the risk. And that's even for women without a family history. actually hereditary or genes you can inherit the genes from your father as well as your mother, and often men do not get breast cancer, although a few do get breast cancer, but they just have very limited breast tissue as compared to a female. So it could be that such an inheritance of a risk gene went through the male line of your ancestry, and so it's not that apparent. And some of these genes, BRCA1 and 2, we know that a woman who is a carrier of a BRCA1 mutation has up to 60 to 80% risk to develop breast cancer. So if that's the case, then in families you often see several women who develop breast cancer in the past, and often one or two at age before 40 or 50. But there are other genes where the risk is maybe that 1 in 4 will develop breast cancer. And CHEK2 is one of those genes. So if you are a carrier of a mutation in CHEK2 and only your risk is 1 in 4, it's not likely you will see in multiple generations in a family many women with breast cancer, because the risk is 1 in 4. So that's why we chose to do these 9 genes that covers the risk, or the genes that give this very high risk, like BRCA1 and 2, but also includes several of those genes that give this 1 in 4 risk. 1 in 4 women will develop breast cancer risk, because that's already enough to actually guide the screening frequency. And if a person, which is 90% of all women, has none of that, then you can actually reduce screening safely to every other year. And actually in the Netherlands, where that's already the standard right now, they're thinking of that for some 70% of women, you can reduce it to 1 in 3 years. But that for the United States is currently not in any recommendation. So for the Wisdom study, we took every other year as a minimum screening interval. So this is ongoing, and you can indeed join the Wisdom study at thewisdomstudy.org, just online. It's very easy. And I think we will be able to show results whether the risk-based screening is more effective and more preferred in the next 5 to 10 years.
Excellent. It would be great if we could also have the Wisdom study available globally. I think everyone would benefit from that.
It's not available globally, but we have partner studies, actually one in Canada, one in Europe funded by the European Union, which is available in France and several other countries. There is a study ongoing in Australia. So we are in close contact with all of those people. And so we hopefully will be able to combine all of our data at one point to get like a global answer.
So I see that we have another question, and this is about mental health. First, I'd like to know, Dr. Laura Van Veer, if the Wisdom study is looking into mental health as well, or is that something that researchers have been just monitoring during treatment? And also, Angie, I wanted to hear your experience with mental health throughout recovery.
Oh, okay. Me first then.
Yeah, you want to go first? Yes, go for it.
Okay. Mental health. Yeah, I think that plays a huge role. The moment you get the diagnosis, if you're not braced for the fight, I think it would be very difficult to go through chemotherapy, depression, physical wise. Chemotherapy was very heavy, but mentally you have to wake up and fight all the time. So I guess I can speak for for myself. Of course, I can't speak for other patients who've had to fight, and I was still, lucky that it was early stage. So in my mind, it was it was more, how do I, come back from this? How do I recover from this? And having physical therapy, which is, also with the gym, with my chemo sisters, we gave each other a lot of support. So I think that that's also quite important, to have a network of people you can surround yourself with, who can give you support, not just, someone who's going to come over and help with groceries or something. It's more about, how do we find our way back, because we're never going to be the same. And I can say that, it took me, it took a while to overcome a lot of the hurdles of being in treatment and fighting. I mean, you're exhausted. Some days you don't want to. And there are some days still, even now, 2.5 years post everything, post surgery, I find myself fatigued some days. And, you got to have the energy to wake up and get your day going, and be strong to face whatever you have to. But I think that helps me in life, because, we all have challenges that we have to face and go through. So if anything, I think cancer has helped me to become a stronger person, mentally, physically, the best that I can be. And I think that that's really important in my recovery for me, because now, like I said, it's the third version of endocrine therapy. But every time I feel like I'm learning to deal with the side effects, and learning how to cope with it, or learning how to work with it. So I believe that it makes a huge difference in mental strength. And even in my golf, I really thought for a moment I wasn't ever going to be able to play at a high level anymore. It was my passion. In 2017, I was winning tournaments left and right, and I thought, wow, I've got it all. And then suddenly, my life changed completely, and it's already almost 3 years. But I will tell you that I'm feeling more confident, more focused than I have been in the last 3 years. And I think mental health wise, you've got to be strong to be able to find a way to bounce back. So I feel that for me it's helped. But I don't know if other friends who have gone through cancer, how they're dealing with it, because I do know a few people who faced cancer maybe even 10 years ago, and they're still finding it very difficult to overcome that mental block of, like, you're living, it's okay, come on, you can make it through this, because there's still blocks with finding their path to recovery. And that's maybe 10 years ago, or even someone I went through with chemo, they're still fighting all the side effects, all of the same feelings of what chemotherapy felt like. So some friends still haven't gone through the recovery stage, I guess, and it can be 2 or 3 years already down the line. So I don't know, Dr. Venderveer, what can be done to, besides seeing a therapist, of course, but can help for recovery for patients who are finding it very difficult to get over that hurdle of feeling like they are starting to recover?
Yeah, I think, first of all, thank you for the question. I think it's a real good question. I'd like to answer the question in two ways. So if you would ask me as a scientist, looking at the effect of a treatment, and I look at sort of, yes, recurrence, no recurrence, die of the disease, no die of disease, I don't think we have evidence that mental health actually will affect the actual recovery of preventing a recurrence or not. But having said that, of course, then I'm looking at sort of like very clean data, but in the meantime, it's patients who are being treated. And so more and more, the physicians, patients, advocates recognize, of course, that the well-being of a patient is part of a treatment effect and health effect, maybe even beyond mental health, but health as a whole. So while drugs have been, and tests like I've developed, have been evaluated based on these sort of like clean endpoints, recurrence, yes, no, there's of course a whole quality of life effort. And so while, for instance, by the FDA, drugs are approved based on yes, no recurrence, for instance, or yes, no progression in case of metastatic disease, more and more people start to include quality of life measures. So, and also the FDA is really interested in actually beyond survival, yes, no, to actually add a clinical benefit index. And the clinical benefit index means that both the survival effect as well as the quality of life effect will be included. Because if a treatment is very, very good, but it has so many side effects that it actually affects your mental health in a way and your total health, then maybe it's not worth giving that treatment. So I think in those studies where this clinical benefit index is being developed, also many patient advocates are participating. And I think in the end, when there are many treatments one can choose, one should also choose based on the clinical benefit index, so that a person can really weigh benefits versus harms, and make an initial decision, and maybe rethink and make another decision later on in the treatment. So in that way, I can say yes, mental health plays a role in recovery, because we're working towards setting up this clinical benefit index. And I think thanks to participation of many patients, that's possible.
Mm-hmm.
I think we don't hear you.
Oh, yeah.
Sorry about that. I think we have 2 minutes left on the clock, and it's time for us to wrap up. But any last thoughts you'd like to share, Angie? What are your hopes to see in the future in terms of breast cancer research and treatment? And Laura, what would you like to see in the future in terms of your work in research?
Okay, I'll go
Angie,
first
you'd like to start first.
Yes, there are probably two things I'd like to see happen for future breast cancer research. Most importantly, the research that a lot of research is poured into early stage, but I'd like to see perhaps more research for advanced breast cancer. For instance, I have a friend who, 14 years breast cancer free, and then suddenly, out of the blue, at least that's how she felt, it's back, it's recurred, and that's a 14-year span, and now it's it's stage 4. So for her, it's devastating, and I think that's also a thought for me. I mean, right now I'm 2.5 years from initial diagnosis, but what about down the line? What will happen? So that's something that sticks with me. But overall, I think breast cancer is something that has taught me a lot. So it's given me the opportunity to find my strength, and that's something that I do know that I would like to perhaps do more of, where I can help raise awareness, or do more. So for myself, I'd like to also continue in more learning more with research, but most importantly, maybe if we can do more to help advance breast cancer research for advanced breast cancer, that's really truly something I'd like to see more in the future.
I can maybe partly answer your question, and I also have my own future outlook. But so I think more and more scientists like me and others are able to actually study advanced breast cancer and metastatic breast cancer in a more comprehensive way. And sometimes you need to wait until the technology is ready to do that. Because when there is advanced or metastatic disease, often the disease has sort of evolved into many different diseases at once. So we need the technology so that we can recognize what we call the heterogeneity. Whereas in the early stages, there's more one pattern of the disease. I mean, that's not completely already, I mean, there's already some differences, but in metastatic disease, many more. So the technology now allows us to also look more into the heterogeneity of all the different locations or how the tumor has developed. And there's a lot of activity ongoing, and that's maybe not directly visible for patients right now because it's still more in what we call basic research, but it's moving there. So I think we will be able to move forward there as well. I think my own outlook, what I would like to see happen, is that I often have to remind myself that I work in like an academic setting, hospital. And so patients who go to such hospitals are able to sort of get access to the newest treatments, the newest diagnostics. But I think we need to realize that many, many more patients are treated in hospitals, in other settings. And so we need to make sure that they get access to all of these developments as well. And I hope that in the next 5 to 10 years will really happen.
Mm-hmm.
Okay, well, I'm sorry, unfortunately, we are out of time. It's already 1:03 over here in California. Thank you to everyone who joined, and many thanks to our panelists, Dr. Laura Van Veer and Andrew Trang Nguyen for joining the panel today. For all of you who are viewing, this recording will be posted on our YouTube channel, so please be sure to subscribe to QBI TV. Thank you all for your time, and I look forward to seeing where we are in terms of cancer research in the future. Thank you.
Thank you.
Thank you.